Hello everyone, it's Dr. Locklear here, and I'm coming to you with Exemplar 10C, Inflammatory Bowel Disease. This is a painful disease and a disease that is, I don't know what the word is I want to use. It can be a little annoying and it can cause a lot of problems. So we're going to talk about irritable bowel, ulcerative colitis, and Crohn's disease. So let's get started. I thought y'all would get a kick out of this little picture here. It just goes to show you how angry ulcerative colitis can be and how intense it is. So what is the patho of irritable bowel and ulcerative colitis and Crohn's disease? We're going to look at that. How does it work? How does it take place? What is the cause? What are the risk factors? And what are the clinical manifestations? What kind of symptoms will we see? What are some of the tests and therapies used to help treat and diagnose this disorder? And what do we see in the differences across the lifespan? And then how do we apply the nursing process? So what do we assess for in these patients? So what is our overview? Irritable bowel disease is an umbrella term for two chronic inflammatory conditions of the intestines. Ulcerative colitis, or UC, is a remitting and relapsing inflammatory process. Remitting and relapsing means that it will have periods of remission and then reoccur, and remission, reoccur, so it keeps coming back. It affects only the mucosa layer of the colon and almost always includes the rectum. Crohn's disease is a transmural inflammatory disease that can affect any portion of the GI tract from the mouth to the anus, but it usually affects the terminal ileum and proximal colon. Areas of disease involvement appear as patches, leaving adjacent areas unaffected. Crohn's disease can lead to fibrotic strictures due to the transmural effect on the colon, and it may lead to micromutations and fistulas as well. And here's a picture of what Crohn's disease may look like and the little fissures that you have. This is a normal bowel versus the one with the opening and the tears in the bowel itself. So the inflammatory process of UC usually begins at the rectosigmoid area of the anal canal and progresses proximally. In most patients, the disease is confined to the rectum and the sigmoid colon. It may progress to involve the entire colon, stopping at the ileocecal junction. UC begins with inflammation at the base of the crypts of the libercuin in the distal large intestine and rectal mucosa. Microscopic pinpoint mucosal hemorrhages occur and crypt abscesses develop. These abscesses penetrate the superficial submucosa and spread laterally, leading to necrosis and sloughing of bowel mucosa. Further tissue damage is caused by inflammatory exudates and the release of inflammatory mediators such as prostaglandins and cytokines. The mucosa becomes red and edematous because of vascular congestion, friable, easily broken, and ulcerated. The mucosa bleeds easily and hemorrhage is common. Edema creates a granular appearance. Pseudopolyps, tongue-like projections of bowel mucosa into the lumen, may develop as the epithelial lining of the bowel regenerates. Chronic inflammation leads to atrophy, narrowing and shortening of the colon, with loss of its normal haustra, small pouches or recesses into which the large intestine is divided. Crohn's disease typically begins as a small inflammatory aphthoid lesion, a shallow ulcer with a white base and an elevated margin, similar to a canker sore of the mucosa and submucosa of the bowel. The initial lesions may regress, or the inflammatory process may progress to involve all layers of the intestinal wall. So when you have Crohn's, it's all about the wall and the inside of the bowel, and it can be in one spot or throughout the bowel. It's not just localized. Deeper ulcerations, lesions and fissures, which are knife-like clefts that extend deeply into the bowel wall, develop. The inflammatory process involves the entire bowel wall, the transmural wall. The lumen of the affected bowel in Crohn's disease assumes a cobblestone appearance as fissures and ulcers surround the islands of intact mucosa over edema submucosa. The inflammatory lesions of Crohn's disease are not continuous, rather they occur as skip lesions and intervening areas of normal appearing bowel. As Crohn's disease progresses, fibrotic changes in the bowel wall cause it to thicken and lose flexibility, taking on a rubber hose-like appearance. The inflammation, edema, and fibrosis can lead to local obstruction, the development of abscesses, and the formation of fistulas between loops of bowel or between the bowel and other organs. Fistulas between loops of bowel are known as enteroenteric fistulas. Fistulas that occur between bowel and bladder are known as intervisceral fistulas, and fistulas that occur between bowel and skin are known as endocutaneous fistulas. Perineal fistulas are relatively common, originating in the lumen. Depending on the severity and extent of the disease, malabsorption and malnutrition may develop as the ulcers prevent absorption of nutrients. When the jejunum and ileum are affected, the absorption of multiple nutrients, including carbs, proteins, fats, vitamins, and folate, may be impaired. So we know when that's impaired, we're not absorbing them, and we're going to feel the effects of that. Disease in the terminal ileum can lead to vitamin B12 malabsorption and bile salt reabsorption. The ulcerations also can lead to protein loss and chronic slow blood loss with consequent anemia. So what is the etiology of these diseases? The etiology of both UC and Crohn is unknown. Genetic and environmental factors have been implicated. Factors such as infectious agents and altered immune responses are also thought to play a role. Autoimmunity is also thought to play a role, and lifestyle factors such as smoking can be an issue as well. So what are the risk factors? Age is a risk factor, with onset usually between 15 and 30 years, and possibly another peak between 50 and 80. White populations have an overall higher rate of Crohn's and UC, especially American Jews of European descent, but rates of both disorders are increasing in Black and Hispanic populations as well. So we're starting to see a rise, and it could be related to some lifestyle factors. Prevention. While at this time there are no recommendations for prevention in relation to inflammatory bowel disease, a healthy lifestyle, physical activity, adequate sleep, and a healthy diet is good advice for all patients, and that's with anything. Clinical manifestations. While UC and Crohn's disease have similar clinical manifestations, their presentations differ somewhat. With both UC and Crohn, the patient experiences periods of symptom-free remissions and sporadic periods of active disease or flare-ups. Look at table 10.5 and you can see the comparison. This is on page 739. So it gives you the characteristics. It lists ulcerative colitis and then Crohn's disease. I would read over that when you are reading. Diarrhea is the predominant manifestation of UC. There are scoring tools that can be used, however, those are usually used in research only. So for mild UC, Patients with mild clinical disease have 4 or fewer stools per day with or without small amounts of blood, no signs of systemic toxicity, for example, no tachycardia, and a normal CRP and/or ESR. Mild cramping, abdominal pain, tenesmus, a painful but ineffective urge to defecate, and periods of constipation are also common. But severe abdominal pain, profuse bleeding, fever, and weight loss are not part of the spectrum of the mild disease. Moderate UC. Patients with moderate clinical disease may have frequent loose bloody stools, 4 to 6 per day, mild anemia not requiring blood transfusion, hemoglobin greater than 10, and abdominal pain that is not severe. Patients have no or minimal signs of systemic toxicity. Adequate nutrition is usually maintained and weight loss is not associated with moderate clinical UC. Severe. Patients with a severe clinical disease typically have frequent loose bloody stools, 6 or more per day, with severe cramps and evidence of systemic toxicity as demonstrated by a fever, temperature greater than 37.8 degrees Celsius, tachycardia, heart rate greater than 90 beats per minute, anemia, hemoglobin less than 10, and or an elevated CRP or ESR. And ESR is your sedimentation rate. UC is also associated with pancreas and hepatobiliary system issues. For the pancreas, there can be an acute or chronic pancreatitis, either preceding diagnoses or as a complication. Sclerosing choangitis, inflammation leading to scarring and narrowing of the bile ducts, which then leads to potential severe liver disease, may also occur as well. Intestinal complications of UC include hemorrhage, perforation, and rupture of the bowel, or fulminant colitis, which may advance to toxic megacolon. Hemorrhage, which is the most common complication, often results in anemia. Perforation occurs when the intestinal wall is weakened, and you can see in the picture here is a picture of a perforated bowel. In other words, it's got a hole in it. The opening allows the intestinal contents to leak into the abdomen and cause peritonitis, which can lead to sepsis. It occurs when damage to the entire thickness of the intestinal wall results in intestinal dilation and paralysis and abdominal distension. Toxic megacolon, which is really large, a rare form of fulminant colitis, is the most severe complication of UC. In addition to the transverse colon dilating more than 6 centimeters, the resulting paralysis allows excessive amounts of intestinal gas to collect and causes severe abdominal distension. It may result in perforation of the bowel if left untreated. Causes of toxic megacolon include hypokalemia and the use of antidiarrheals, opiates, antispasmodics, and certain antidepressants. According to the American College of Gastroenterology practice guidelines, patients with UC are at increased risk for colorectal cancer proportion to disease duration, extent of inflammation, and amount of colon involvement. For those at highest risk, yearly colonoscopies are recommended. For those at lower risk, every 1 to 3 years is recommended. For Crohn's disease, because involvement of the GI system in Crohn's disease can be so diverse, manifestations vary among patients. The majority of individuals with Crohn's disease experience persistent diarrhea. Stools are liquid or semi-formed and typically do not contain blood, although blood may be passed if the colon is involved. Abdominal pain and tenderness are common. The pain may be located in the right lower quadrant and relieved by defecation. A palpable right lower quadrant mass is often present. Systemic manifestations such as fever, fatigue, malaise, weight loss, and anemia are common. Anorectal lesions such as fissures, ulcers, fistulas, and abscesses are also common and may occur years before intestinal disease is apparent. If the stomach and duodenum are involved, nausea, vomiting, and epigastric pain may occur. The severity of Crohn's disease is based on the Crohn's Disease Activity Index, or the Harvey-Bradshaw Index. Both of these indexes correlate with each other, so either can be used. So for this index, you have clinical remission, CDA4 less than 150. These patients are asymptomatic and without symptomatic inflammatory sequels. The status is achieved either spontaneously or after medical or surgical intervention. Patients requiring glucocorticoids to remain asymptomatic are not considered to be in remission but are referred to as being steroid dependent. Mild Crohn's disease, 150 to 220 CDAI score. These patients are typically ambulatory and tolerating an oral diet. They have less than 10% weight loss and no symptoms of systemic disease such as fever, tachycardia, abdominal tenderness, and no signs of symptoms of instruction. Moderate to severe Crohn's disease, CDAI, you get a score of 220 to 450. This group comprises patients who have failed treatment for mild to moderate disease, or those patients with prominent symptoms such as fever, weight loss, abdominal pain, and tenderness, intermittent nausea or vomiting, or anemia. Severe fulminant Crohn's disease, CDAI greater than 150 score. Patients with persistent symptoms despite glucocorticoids or biologic agents as outpatients, or individuals presenting with high fever, persistent vomiting, intestinal obstruction, peritoneal signs, cachexia, or evidence of an abscess. Certain complications of Crohn's disease, intestinal obstruction, abscess, fistula, are so common that they are considered part of the disease process. For many patients, the disease initially presents with one of these complications. Intestinal obstruction is a common complication caused by repeated inflammation and scarring of the bowel that leads to fibrosis and stricture. Obstruction of the bowel lumen causes abdominal distension, cramping pain, and boringomia, or excessive loud and hyperactive bowel sounds. Nausea and vomiting may occur as well. Fistulas may be asymptomatic, particularly if they occur between loops of small bowel. An abscess caused by fistulization produces chills and fever, a tender abdominal mass, and leukocytosis. A fistula between the small bowel and the colon may exacerbate diarrhea, weight loss, and malnutrition. When the bladder is involved, recurrent urinary tract infections occur. Perforation of the bowel is uncommon, but can lead to generalized peritonitis. Massive hemorrhage is also an uncommon complication of Crohn's disease. Long-standing Crohn's disease increases the risk of colorectal cancer. So, Crohn's disease affects that bowel in such a way, that you can have all kinds of issues, not just dealing with the Crohn's, but it can lead to cancer and other things. So what is our collaboration with Crohn's and ulcerative colitis? Interprofessional care for irritable bowel disease begins by establishing the diagnoses and the extent and the severity of the disease. Treatment is supportive, including medications and dietary measures to decrease inflammation, promote intestinal rest and healing, and reduce intestinal motility. Many patients with IBD require surgery at some point to manage the disease or its complications. As a member of the healthcare team, the nurse plays an essential role by providing patient teaching about disease management. So we're trying to prevent it. Once you have it, there's no getting rid of it, but you're trying to prevent the episodes. We teach about diagnostic tests and any surgical interventions and treatments that are necessary. Diagnostic test. Diagnostic testing establishes the diagnosis of IBD, assesses the extent of the disease, and evaluates the effects of the disorder. A sigmoidoscopy, colonoscopy, or barium upper and lower X-ray series inspect the bowel mucosa for characteristic changes of IBD. Laboratory tests used to differentiate IBD and to identify effects and complications of the disease include a stool examination for blood and mucus and stool cultures to rule out infections, causes of the bowel inflammation, and diarrhea, or infectious causes. CBC with hemoglobin and hematocrit shows anemia from chronic inflammation, blood loss, and malnutrition, as well as leukocytosis due to inflammation and possible abscess formation. The sedimentation rate is typically elevated during periods of acute inflammation, and the sedimentation rate is indicative of inflammation. Serum albumin may decrease because of malabsorption, malnutrition, protein loss through intestinal lesions, and chronic inflammation. Folic acid and serum levels of most vitamins, including A, B complex C, and the fat-soluble vitamins A, D, E, K, often decrease malabsorption. Liver function tests may show elevated liver enzymes such as your ALT, alkaline phosphatase, AST, GGTP, and LDH, and bilirubin if sclerosing cholangitis is present. So you need to look at a lot of labs. Surgery interventions for IBD differ depending on the primary disease process and the portion of the bowel affected. Surgery is generally performed only when necessitated by complications of the disease or failure of conservative treatment. So they try to, treat you with medications and not have to go in and remove your bowel, because if they remove too much of it, you may end up with a colostomy. So in Crohn's disease, bowel obstruction is the leading indication for surgery. Other complications that may require surgical intervention are perforation, internal or external fistula, abscess, and perianal complications. The usual treatment is resection of the affected portion of the bowel with an end-to-end anastomosis to preserve as much bowel as possible. The disease process tends to recur in other areas following removal of the affected bowel segments. So they'll remove it and attach the ends of like if they cut a piece out in a certain spot, they'll attach those two ends where the gap is. The disease process tends to recur in other areas following removal of affected bowel segments. The risk of fistula formation increases following surgery. Bowel strictures may be treated with a strictureplasty, in which longitudinal incisions are made in the narrow segment to relieve the stricture while preserving the bowel. So they can go in and remove bowel, and here's a picture of end-to-end, end-to-side, and side-to-side anastomosis. In ulcerative colitis, patients with extensive chronic UC may require a total colectomy, and this is a surgical resection and removal of the colon to treat the disease itself, to eliminate complications such as toxic megacolon, perforation, or hemorrhage, or to serve as a prophylactic measure against the high colon cancer risk associated with extensive UC. The surgical procedure of choice is a total colectomy with an ileal pouch and anastomosis. In this procedure, the entire colon and rectum are removed, a pouch is formed from the terminal ileum, and the pouch is brought into the pelvis and anastomosed, connected to the anal canal. A temporary or loop ileostomy, and they show that in a picture below, is generally performed at the same time and is maintained for 2 to 3 months to allow anal anastomosis to heal. When the healing is complete, the ileostomy is closed and the patient has 6 to 8 daily bowel movements through the anus. Advanced age, obesity, and other factors may preclude an IPAA. For these patients, a permanent ileostomy or continent ileostomy may be created. And so on page 741, you see the appearance of a stoma. So they've gone in and pulled the bowel up and made the opening, then the pouch goes over it and the bowel movement will come through that. To keep this PowerPoint from being so lengthy, I want you to read over ostomy yourself. And this is just talking about, the ostomy and how they make the ostomy and all of that. Okay, so make sure you read over that. Okay, and you have the different types of ileostomy, loop ileostomy, and a continent ileostomy. And the more, if your ileostomy is in the small bowel, your output of bowel will be more liquid. If it's lower down to lower parts of the colon, you'll have more foreign bowel movement come through the colostomy. So pharmacological therapy. So what are we looking at here? The goals of care are to treat acute attacks of inflammation as quickly as possible, to reduce the incidence of relapse, and to control chronic intestinal inflammation. Drug therapy plays a key role in achieving these goals. And you'll see medications on page 10, medications 10.3 on page 743, and it lists the different categories, your corticosteroids, tumor necrosis factor, antagonist medicines. Look over those. Just look over those and look how they work. I can't put all that in here because this PowerPoint would be too long, but please read over that. Stelara, that one's advertised a lot, and Xeljanz is advertised a lot on TV about ulcerative colitis and Crohn's, so please look at that. Drugs are used to treat irritable bowel are given via the following routes, administered orally, subcutaneously, or IV to act systemically to reduce inflammation. Orally as a time-release drug that dissolves in the ileum and upper colon to act locally, or rectally as an enema to act locally to reduce inflammation. Drug categories used to treat inflammatory bowel disease include 5-aminosalicylic acid derivatives, corticosteroids, 3 categories of biologic therapies. And again, look at medications 10.3 table. For acute exacerbations of IBD, corticosteroids are given to reduce inflammation and induce remissions. Many patients are unable to withdraw from corticosteroid without experiencing relapse and may need long-term low-dose therapy. But long-term use of steroids can cause a lot of problems, diabetes being one of those. Irritable bowel syndrome has been linked to several strains of pathogenic bacteria in the colon. The use of antibiotic or antiprotozoal drug therapy has sometimes been part of the treatment, especially in the case of the occurrence of intestinal abscesses or fistulas. Chronic diarrhea can be an unpleasant effect of IBD. Antidiarrheal agents such as Imodium and Lamodal may be given to slow the GI motility, which reduces the diarrhea. These drugs are safe for patients with mild and chronic manifestations, but they are not given during acute attacks. That's important to know. Drug therapy for IBD should be continued even when the patient is asymptomatic. Because of the drugs used to treat IBD suppress the immune system, the patient should avoid the risk of exposure to infectious diseases. Report any disease symptoms or fevers to the healthcare provider, and always remember to mention that current treatment for IBD when being treated for any other medical condition. Immunization schedules for pediatric patients may need to be altered when the patient is currently being treated with immunosuppressive drugs. So it's important to read this and know what these drugs do, because they don't all do the same thing. Some treat inflammation, some treat infection, some help with suppression. So here on this slide, you have to be careful to not be exposed to infectious diseases because they can cause immunosuppression. And if you're a patient that's already immunosuppressed with something like AIDS or some disease that does that, cancer, these drugs may not be used at all. Non-pharmacologic therapy. Antigens in the diet may stimulate the immune response in the bowel, exacerbating IBD. As a result, dietary management should be individualized. Some patients benefit from eliminating milk and milk products from the diet. Increased dietary fiber may help reduce diarrhea and relieve rectal manifestations. But it is contraindicated for patients with intestinal strictures caused by repeated inflammation and scarring. All food may be withheld to promote bowel rest during an acute exacerbation of Crohn's. Nutritional status during this time is maintained by enteral or total parenteral nutrition, which is TPN. TPN carries a higher risk of complications than does enteral nutrition. An elemental diet such as Ensure, which contains all essential nutrients in a residue-free formula, may be prescribed. Eliminating diets provide essential nutrients to the small bowel to support cell growth, but are not always palatable. In other words, they may not always taste too good. Complementary health approaches. The chronic nature of IBD and the adverse effects of the many prescribed treatments lead many patients with IBD to seek or use integrative therapies. There is some preliminary evidence that suggests probiotics may improve the symptoms. However, benefits have not been conclusively demonstrated, and I see a lot of probiotics given out in clinical practice. That's kind of the new thing. The lack of research to determine the effectiveness and safety of most alternative therapies in the treatment of IBD, especially herbal supplements, limits the use of those therapies by conventional practitioners. In addition, many integrative therapies used by patients with IBD may interact with prescribed medications such as like your blood thinners, Coumadin and stuff. Nurses should instruct patients to discuss all potential therapies with the healthcare provider. Quality of life can be low with increased stress levels, depression, and fatigue with these patients. Mindfulness training, cognitive behavior therapy, and stress management can help with improving quality of life. Exercise such as a 30-minute walk, abdominal massage, and a warm bath relaxes the rectal muscles are self-care measures that can help patients manage the discomfort. Children and adolescents, again, I'm going to let you read that on your own to keep this from being so lengthy. So you can read through that. Make sure you read the children and adolescent section. Make sure you read the section for women and then make sure that you read the section for older adults as well. And then we're going to jump right into the nursing process. Although at this time IBD cannot be predicted or prevented, effective management may help the patient avoid complications of the disease. Stress the importance of adhering to the prescribed treatment regimen because if you adhere to it, it's going to help control your symptoms. And prompt reporting manifestations of exacerbations to your healthcare provider. So even if you're on stuff, you need to report, if you're still having symptoms because they may need to change your medications. A thorough assessment is required for patients with IBD. This includes a psychosocial assessment, especially if there are concerns about patients not adhering to the treatment. This is especially true with adolescents who want to fit in with peers and not to be different because they may be on special diets and can't do some of the things that their peers are doing. The observation and patient interview. The nurse should assess current manifestations including onset, duration, and severity of symptoms, number of stools per day, presence of blood or mucus in the stool, abdominal pain or cramping, and tenesmus. Usual diet, ability to maintain weight and nutrition, and food intolerances. Associated manifestations such as arthralgias, fatigue, and malaise. Current medications and previous treatment and diagnostic tests. The physical exam. The nurse should document general appearance, their weight. You're looking for weight loss. Vital signs, looking for changes. Have they been losing a lot of blood? So is their blood pressure low, pulse up? Including orthostatic vitals and temperature. Abdominal assessments, including shape, contour, and bowel sounds. Palpation for tenderness and masses and presence of stoma or scars. So you need to do a thorough assessment of the abdomen and ask those thorough questions. The diagnoses, these are listed here for you on page 745. Risk for fluid volume deficit because they're losing volume, weight loss, constipation, diarrhea, acute pain, chronic pain, anxiety, and disturbed body image. Planning. Planning the care of the patient with either UC or Crohn's disease should be collaborative between the healthcare team and the patient. IBD is a lifelong and potentially life-altering diagnosis. Incorporating the patient's wishes will help to achieve mutually decided on goals. You never leave the patient out, okay? The patient will optimize nutritional status, including macro and micronutrients and adequate hydration during exacerbations of the disease and during times of remission. The patient will develop healthy and positive coping strategies for dealing with the impact of the disease. The patient will be able to provide self-care related to the disease, including prevention and management of exacerbation. So that's your plan. The implementation. Teaching is a major aspect. You have to teach them what to do and really enforce it in that they need to stick to the regimen plan. Diarrhea and disturbed body image are significant problems. Children and adolescents often have specific needs, especially related to body image and the desire to fit in with peers. With severe disease, impaired nutrition must be considered a priority problem. As with other related GI disorders, the first intervention may occur with the acute care environment during an acute exacerbation of the disease. And so, as they start to develop this disease and it starts first happening, this is when you're going to start to see them having a need to deal with this situation. Monitor fluid volume. During an acute exacerbation IBD, diarrhea can be frequent and painful. The frequency of defecation, and that can affect your schedule too. Why, if you're trying to work and you're constantly running to the bathroom? So the frequency of defecation and associated abdominal pain and cramping may interfere with ADLs and increase the risk for hypovolemia, low volume, and impair skin integrity. If a patient's in the hospital, they use a stool chart to record the frequency, amount, and color of stools, measure and record liquid stool as output. The severity of diarrhea is an indicator of the severity of the disease and helps determine the need for fluid replacement. And count, you want to count how many they've had. Monitor vital signs every 4 hours and more if needed. You're looking for tachycardia, tachypnea, and fever, may be indicators of hypovolemia. Weigh daily and record. Rapid weight loss over days to a week usually indicates fluid loss, whereas weight loss over weeks to months indicate malnutrition. Assess for other indications of hypovolemia: warm, dry skin, poor skin turgor, dry, shiny mucous membranes, weakness, lethargy, complaints of thirst. The extent of fluid loss may not be readily evident with diarrhea, particularly if the patient uses the bathroom without assistance. Systemic manifestations of fluid volume deficit may be the first indications of the problem. Maintain bowel rest by keeping the patient NPO, nothing by mouth, or limiting oral intake to elemental feedings as indicated. Bowel rest during acute exacerbation promotes healing and reduces diarrhea. It gives the bowel time to calm down. Administer prescribed anti-inflammatory and anti-diarrheal medications. Anti-inflammatory medications reduce the extent of bowel inflammation and diarrhea. Unless contraindicated, anti-diarrheal medications help reduce fluid loss and decrease comfort because they stop the number of bowel movements that you're having per day. Maintain fluid intake by mouth or IV as indicated. The patient with IBD requires fluid to replace ongoing losses as well as fluid to meet the usual daily needs. If an elemental diet or TPN is prescribed, additional fluids may be required, such as D5W or lactated ringers. Provide good skin care. Fluid deficit and tissue dehydration increase the risk for skin excoriations and breakdown. Assess perineal area for irritation or denuded skin from diarrhea. Use gentle cleansing agents such as peri-wash or tucks, diaper wipes, cotton balls saturated with witch hazel. Witch hazel helps dry up the moisture in the skin. Apply protective creams such as zinc oxide-based preparation to protect the skin from the irritating effects of the diarrheal stool because it's like a barrier to the skin. Digestive enzymes in the stool are very corrosive, increasing the risk of skin breakdown. When patients are being discharged, remind them that the intestinal swelling associated with IBD may cause constipation. In addition to promoting adequate fluid intake, instruct the patient to take only laxatives recommended by the healthcare provider. All laxatives should be avoided during a flare-up of the disease. Also explain non-pharmacological interventions to help relieve constipation. These include maybe exercise, 30-minute walk a day, abdominal massage, and a warm bath. If these treatments are ineffective and the constipation continues from an extended time, contact the healthcare provider. Inform the patient to take constipation seriously. In addition, the abdominal discomfort it causes, it may be a symptom of impaction or bowel obstruction. Safety alert. The patient should be taught to observe stools for obvious blood and test for occult blood as indicated. Report grossly bloody stools which may indicate hemorrhage and necessitate emergency surgery. So a lot of information there. The next one is promoting a healthy body image, and I will let you read that on your own, okay? And then adequate nutritional intake. It talks about high calorie, high protein, low fat, restricted milk and milk products. Parenteral nutrition or TPNs if required, or elemental enteral nutrition if required. Please read over that as well, because I'm trying not to make this too long. Our expected outcomes are the patient demonstrates absence of GI distress, so it's cleared up, it's gone. The patient and family demonstrate successful management of medications without adverse effects. The patient demonstrates no signs or symptoms of infection. So in other words, they're starting to heal up. The patient verbalizes attainment of a positive body image, because this can be very emotionally draining to a patient. The patient demonstrates integration of relaxation techniques into daily life. If the patient does not progress satisfactorily to the expected outcomes, the nurse must complete a thorough assessment, particularly the patient's reported pain level, diet tolerance, and vital signs. Signs and symptoms of infection, such as elevated temperature and increased pain, will require notifying the patient's primary healthcare provider. Further diagnostic workup may include a CBC and blood cultures to rule out sepsis. IV fluids may be reinstated, as well as IV pain medications, NPO status, and IV antibiotics. Surgical consult may be conducted as well. And I will have a case study in class for you regarding this particular topic. Thank you.